you very much for joining us. This is Dr. Mark Moran. We are here to help you understand what's going on in your life with your pain, with your back, and anything else we can help you with as far as community involvement. This is my good friend. What's your name?
I'm actually really bad about that. Like somebody I've known like for 15 or 20 years, and I'm like, I stumble with their name when I get put on the spot. So yeah, Kevin Barton. I'm a chiropractor. I've known Dr. Moran for how long we know each other? Like more than 10 years.
Yeah, it's a long time.
Yeah, a long time.
But we both still look young.
Well, yeah, I hope so.
That's good. It's been a long time.
It has been.
You've been a very good friend and helped me out a lot.
Yes.
So I appreciate that.
Oh, anytime.
So anyone that has problems that needs a chiropractor, go see Dr. Barton. He's a good guy. He'll take good care of you.
Absolutely.
Okay. Next, we got to give a shout out to the wonderful people that are letting us use this room. If you ever have any marketing questions or needs, go to Hapathy and they will take good care of you. And the other shout out I want to do is for Toolbox Studios. They help me with my website and all my marketing. Both of them are very good marketers. Please use them.
Sounds good.
There you go. So what have you been up to?
Man, a lot. We have been through some serious transformations.
You have 15 seconds.
Yes, that's pretty fast. I might be able to do it all in about 15 months.
Oh, okay.
Do we have that much time?
Can you maybe give me just high-level summary?
High-level summary, yes. So we did a little transition with our main practice and brought in an interventional radiology group to start doing interventional radiology procedures. So we are doing anything from knee arthritis treatments through a vascular approach to frozen shoulder syndrome, plantar fasciitis. So we're doing a number of musculoskeletal type vascular procedures, which is cutting edge, super brand new, came out of Japan. A guy in Japan started it about 15 years ago, and it's just kind of made its way to the States in the last 7-8 years. Awesome stuff. We'll talk more about that some other time. But so that, and then we started a brand new therapy with our chiropractic office called scrambler therapy.
Scrambler?
Scrambler. What a name.
Like a breakfast taco at Denny's or something?
Yeah, more maybe like scrambling the brain. No, in a good way.
Whatever.
In a good way.
I like it. Scrambler.
Yeah, we'll talk more about that. We have to talk about that tonight.
Okay.
Super exciting.
I will definitely talk about scramblers.
Yeah.
I just like the name.
Yeah, it's super cool. It's catchy.
Okay.
You'll remember it. You'll be like, do I have peripheral neuropathy? Oh, I heard something about scrambler therapy.
There you go.
Yeah. So
I will not ever forget that.
Yeah, literally. Yeah.
Okay. Well, last time we saw each other, I remember you were expanding to other cities and about to take over the country.
Well, that was the intent. And then apparently the insurance companies had other ideas.
Oh.
And so they went through this in 2022, a 60% cut in those gel injections that we do for the knee. And they literally just squashed our reimbursement so bad that we were like, put on the brakes. And then that's when we brought in the interventional radiology.
So let me get this straight. You have problems with insurances?
Well, every day, all day long, because that's the life I live.
I understand. I feel your pain.
Yes.
And I'm a pain doctor.
Oh man, that's like a double.
I know.
Yeah.
I understand what you're saying.
Yeah.
So.
You should have no pain since you're a pain doctor.
I personally don't have pain, but dealing with the insurance company is frequently painful because they limit things we can do for our patients.
Well, I never really understand how insurance companies get away with practicing medicine without a license. Right? I mean, that's the truth.
Oh yeah,
because they're dictating the care.
100%.
Yeah, and then we'll see crazy things like a pediatrician giving recommendations for a pain procedure or an interventional radiology procedure. I'm like, what in the world?
That's because you're thinking logically.
Exactly.
You can't.
We should throw that out the window because
anytime
you're dealing with an insurance company, not much is logical.
Clearly, I agree.
Yeah,
I agree. Yep. Okay. So anyway, it's good to have you on.
Yeah.
Thanks for coming on.
Well, thank you. I feel honored to be here.
Well, I'm honored that you're here.
Well, good.
It's good. It's good. So I'm going to put you on the spot.
Yes.
So everyone can get to know you a little bit.
Sure.
Teach me the most exciting thing that you ever did in your life.
The most exciting thing I've ever done in my life. I mean,
because you've done a lot of exciting things.
I do a lot of exciting stuff. I am a bit of an adrenaline junkie to some degree. I fly a lot of airplanes. I've been flying airplanes for 25 years. Probably the most exciting thing was learning how to fly helicopters during COVID.
Okay. So I remember you were doing that.
Yeah. I had a lot of time on my hands. I had always wanted to do it. And I was like, I'm going to get my helicopter license. And I did that, bought a few helicopters. And I mean, there's nothing, in my opinion, nothing more fun than flying helicopters. Almost nothing.
Okay, so you fly multiple helicopters, but you're still late to get here?
Well, I mean, unfortunately, they don't really let us land these things anywhere.
You can't land on top of the building?
No, they tend to frown on that.
That'd be great if you could do that.
Without permission, at least. Yeah.
I'm giving you a hard time.
Yeah.
That's awesome. I thought it'd certainly be like swimming with the sharks.
I do like swimming with sharks. That's pretty fun, too. Oh, I tell you, I did have an amazing experience recently. I spent a month in Southeast Asia.
Oh, really?
By myself.
Wow.
And it was a phenomenal trip. Started in Singapore, went to Bali, but I spent 2 weeks on a liveaboard dive boat and dove 4 times a day. Tons of sharks, tons of manta rays. If you've never seen a manta ray in real life, let me tell you, it's unbelievable. The span was like 15 feet. On one dive, we saw over 30 manta rays on one dive. Wow. It was insane.
Okay.
So that was really cool.
Well, I went to Chick-fil-A last night. Does that count for anything? Or
that's not super exciting.
Is it though? I think it is.
Yeah.
Certainly probably not as
depends.
excited as you. I mean, Mara,
it's all relative.
Diving, Asia, or Chick-fil-A. I mean,
it's all relative.
It's all relative.
Yeah.
I knew you'd have a more exciting story than I would have.
Sure.
Okay. Well, thanks for sharing that. I appreciate that. So what we're doing here is we want to try and help people out. Educate them because knowledge is power.
Yes.
Okay. We want them to be active participants, not passive recipients in their health.
Absolutely.
So we want to empower them with knowledge so they won't hurt themselves and then they don't come see us.
No kidding.
We'll try to prevent them from coming see us.
Absolutely.
Right. So can you tell me and our viewers, appreciate that, some examples of common things you see during the wintertime, the holidays coming, and what people can do to help prevent those injuries? Teach me something, and then I'll teach you something.
Absolutely. I think of 2 things. When I think of Christmas, I think of unnecessary falls off ladders from putting up Christmas lights.
That's what I was going to say.
Seriously?
Yeah.
Yeah.
People reaching to the side.
Oh, man. I mean, I can't tell you how many people, had a really bad injury, like obviously a femur fracture or something worse, a hip fracture. And then of course they tend to injure their spine simultaneously. And so they're coming to us for their spine problem, but the injury was really much worse in terms of fractures and things like that. So that's top of mind. Number 2 would probably just be lifting heavy boxes for this or that. And my big thing, and as far as teaching patients and education, is don't lift and twist at the same time.
Yeah.
Lift and then turn your hips and turn your legs and turn your body. But don't lift and twist at the waist, because that's how we shear. That shearing motion on the disc is what hurts the disc under compression. So a compressive load with the shear is how a lot of people rupture the disc.
Right. And the example I see of that is when older people, or I'll say people with more life experience, go to see their families and they bend down to pick up a grandkid and then they lift and twist the kid up like that.
Absolutely.
See that all the time.
Yes.
And the other thing I see is luggage. When you're on a flight, what do? You lift your luggage up and try to put it on a thing, and you get herniated discs.
Or you can tear your shoulder.
Yeah, exactly.
Literally.
Yeah. I had one patient who bent over to get some casserole or something out of the fridge, and he sneezed at the exact same time. So he was bent over and then increased his pressure in his abdomen and just came up with a horrible bulging disc.
Terrible.
Horrible.
Terrible.
Horrible.
Terrible.
So certainly the ladder thing where you go off to the side is very, very concerning. Don't get on ladders. They're very dangerous.
They are very dangerous.
They lose balance. You'll fall. It'll fall on you. You hurt yourself.
I tell people that all the time. Stay away from ladders.
I know. I often think I should advertise on ladders.
Well, that might be helpful. We might drum up some business.
Like put a stamp above the 3rd step and say, above this level, get ready to call Dr. Maria.
Literally. Yeah. There you go.
So I get that one. I get the lifting thing. I get the casserole thing. The other one I get a lot is people that travel. They stay in hotels or foreign beds, and they get cervical neck pain.
Absolutely.
The beds aren't very comfortable, or it's just sitting there a long time. They get a lot of SI joint pain.
No kidding.
A lot of back pain like that. You see that a lot too?
I do. Thinking of just changing beds and changing pillows. I know me personally, everybody thinks it's really funny when a chiropractor has their own back and neck pain, but I suffer from it too, just like everybody else. It's really hard to adjust yourself. But when I sleep on different pillows, it's like your neck, your body gets used to a certain thing. Absolutely. And then when you switch it up, it's like, ooh, why is my head elevated so much? And then, you wake up with a crick in your neck, or your neck super tight, stiff. It's very common.
Yep. I get that too. See my other list. Doing new things your body is not used to.
Ooh. I mean, what comes to mind there is everybody's getting close to the new year. So everybody's sort of thinking about, okay, what's my New Year's resolution? I'm going to start getting back into the gym, or I'm going to start doing more activity or more walking. And they just bite off more than they should too fast.
Right.
So I think they overdo it.
Absolutely.
Yeah.
I totally agree with that.
Yes.
And my perspective is people that go skiing once a year, snow skiing
totally.
or snowboarding for the first time, or they get with their family and friends and like, oh, I can do that. And they don't realize that they have more life experience this year than last year, and they just do things that their muscles and tendons and ligaments aren't used to or adapted to.
And by more life experience, you mean a little more time has passed?
That's what I mean.
They're not as young as they were.
That's what I mean.
Yes.
They have more life experience. That's just the way I say it.
Absolutely.
It is true. Everyone has more life experience every day.
Every day.
Every day. Good. So we see the same problems.
We do.
We do see that. And you have helped me out a lot with my patients, so thank you very much for all your help.
Yeah, and you've done the same for us.
I appreciate that. But what I want to talk about now is because I have lots of patients that come in and they say, what do you want to do with me? And I say, well, here's your options. Obviously, one of my first options is conservative things like physical therapy or chiropractor.
Yes.
And a lot of patients
And that makes a ton of sense, by the way.
Oh, thank you.
Start conservatively and work our way up.
It seems pretty simple.
It seems pretty simple.
I'm not a rocket scientist.
I don't see that every day, though.
I'm not a rocket scientist.
Yeah.
That's it. Pretty simple. Try conservative things.
Sounds like very good medicine.
Oh, thank you.
Yes.
I appreciate that.
Yes.
So the question they have is, what do chiropractors do that physical therapists can't do? And they just crack my back, right?
Sure.
So give me a quick summary of what a chiropractor can offer you and how they differ from physical therapists and some of the advantages or anything is that we can give for.
I think that's a super good question. Probably when I started out in chiropractic, and I've been practicing for 21 years now, it was probably a little different then than it is now. Most physical therapists do not manipulate the way chiropractors do. Some do, and some have been trained in it, but they don't train every single day of their sort of chiropractic education like we do. And so in my experience, they tend to not be as proficient. It is a skill. It's a very technical skill, and you have to have a feeling for it. And we just have a lot more background in that one major thing, which is, again, very technical. So,
and let me interrupt. When you say manipulate, you're saying that as a movement or joint type thing,
yeah,
not
so
like manipulating the situation.
Yeah, exactly. Right. So we're saying like mobilizing the joint. So if we're mobilizing the spine because it's tight or restricted, or it's stiff or it's tight, probably. I mean, I'm throwing a number out there, but I would say probably less than 10% of physical therapists adjust like a chiropractor would adjust. Okay, some do, but not many.
Okay.
Yeah. So that's probably the main difference. Number two, I would say, in terms of like what I like to do is I think every physician and every practitioner has what they really enjoy doing and seeing. Mm-hmm. I'd like to see the spine patients. I don't really want to see a shoulder patient. I don't want to deal with an ankle problem. I just have my preferences. So I want to see a herniated disc patient or this kind of patient or that kind of patient. And I'm very good at the spine. I let all the physical therapists, like if I have what I would consider a PT issue, like probably rehabbing a shoulder or certainly a post-surgical problem, I'm going to refer that to a physical therapist. I'm going to let them do what they do well. Mm-hmm. And then hopefully, we don't get a lot of referrals from PT, but we send out a lot of referrals to PT.
But what you said I think is very important is what you can do well.
Yeah.
You know what your boundaries are.
Right.
And then when you start operating outside those boundaries, you say, you know what? I need some help, so let me send you to someone who's better at it.
100%.
That's better for the patient. You know what? That makes sense.
Well, that's good. That's good.
That seems like it makes sense.
I always like to go back to let's do what's right for the patient.
Yeah. It's pretty simple.
Yes.
I agree with that. Absolutely. Work inside your wheel well. Know what you do. Do it well. Take care of the patients first. If you can't do it, there's nothing wrong saying, you know what? Let me send you someone who's going to do a better job.
Absolutely.
I do that all the time.
100%.
Appreciate that. Okay, so I cannot wait to hear about scrambled eggs.
Well, I'm pretty good cook at scrambled eggs.
Oh, really?
Yeah.
It's something like that. I can't remember what it was, but I know you said scrambled something.
So scrambler therapy.
Scrambler therapy.
Yeah. So what in my career, I think we've always tried to find, like our organization, we've always tried to find the really neat treatments that we don't feel like are well treated in the medical profession in general. And one of those things is like peripheral neuropathy. I mean, how hard is it to treat peripheral neuropathy?
It's very hard.
It's very hard.
It's very hard.
It's a very common problem.
Especially in San Antonio.
Especially in San Antonio because they're, one of the biggest causes for peripheral neuropathy is diabetic neuropathy.
Right.
Uncontrolled diabetes leads to nerve damage.
And there's a couple of people with diabetes in San Antonio.
One or two, I think.
Maybe. Yeah.
Maybe. And so, traditionally speaking, we have some medications that
Usually it's medicines.
can work pretty well. But when they don't, what are our options? So from your perspective, how do you treat peripheral neuropathy?
Usually it's medicines because
Yes.
it's a peripheral problem. It's vascular. There's not a lot of interventions you could do for vascular problems diffuse throughout the blood vessels. So
Yeah.
usually it's medicines for peripheral neuropathy.
Yeah. And so people will try things, some physical therapy type approaches. They'll try some home remedies. There can be some nutritional aspects,
Sure.
So obviously we want to treat the underlying problem that's causing the neuropathy. But once those things have been treated, unfortunately, once the damage has been done, you're not typically going to reverse those changes. And so what scrambler therapy does is it's actually treating the neural pathway to the brain. So we are literally retraining the brain to understand that this machine generates this signal. It's quite complex. There's 16 algorithms that runs through this code. So it's basically, this is an electroanalgesic device.
Okay.
So think about this like a TENS unit. So the analogy that our trainer, the guy that came and trained us on this thing, he said, it's kind of the difference between a Volkswagen Bug and a Tesla.
Okay.
Yeah. So, Teslas have an amazing ability to drive themselves and they do all this advanced stuff. Are they the same thing? I mean, sort of. But I mean, obviously, one's way more advanced than the other. So this machine generates a synthetic signal to replace the existing painful signal. So it's replacing the previous painful signal with a no pain signal.
It's scrambling the pain
It's
signal.
literally scrambling the pain signal. With a no pain signal, it's sending this new message to the brain, and how the brain works over time, it retrains the pathways to the brain, and the neuroplasticity improves with time. So this is sort of like the analogy we give is, how do you learn a foreign language? So it starts out with a few words, which turns into a few sentences, which turns into some phrases. And the more you do it, the more you learn, and the faster your brain learns it and figures it out. So same principle with neuroplasticity of learning a new pathway. And so eventually we want the brain to recognize this no pain signal as the normal signal. And so where with a TENS unit, you're always placing the pads on the painful part of the body. Where the scrambler therapy, we're actually placing this on good neurons. So we're actually placing this typically proximal or in front of where all the damage to the nerves are.
Okay, so like on the thighs?
Yeah, so if they had, usually it's about 2 finger widths from the problem area. So if they had peripheral neuropathy in their feet, we'd actually place the pads about 2 finger widths away from the problem.
So
like
really
ankle.
close to,
yeah, really close to the problem.
Okay.
But where the neurons are still good, where the nerves are still sending a proper good signal. So then we start overriding that signal to the brain, and this is how we treat peripheral neuropathy. So over time, so this was invented in Rome by a guy named Giuseppe Marineo, and he invented the scrambler therapy like 20 years ago, but it was FDA approved in 2009 in the States. So he sent some machines to the States so they could study it. So most of the studies have come out of Johns Hopkins University, a guy named Dr. Smith there. He's in the pain department. He's an anesthesia pain guy, just like you. So they use this extensively to treat all kinds of neuropathic pain. So we are just sort of getting out the peripheral neuropathy word, but treat CRPS, phantom limb pain. Yeah, CRPS.
Any neuropathic pain.
Any neuropathic pain, literally any neuropathic pain. So we saw some amazing results on some patients in just this week. So this is our first week of the machine. So we're just kind of getting started with it. But so one of the very first patient, peripheral neuropathy patient, diabetic neuropathy, feels like he has sponges on the bottom of his feet. The typical, numbness, right? His burning pain's about an 8 at night. And so when he came into the office, he complained of a pain score of about a 6. Well, obviously with the numbness and the spongy, it never changes. He has very difficult time with balance due to proprioceptive loss. So he has a hard time just walking. So he walks with a cane. So
he loses sensation in his feet, like per session, I'm just saying.
Yes, exactly.
So he doesn't feel where his feet are, so he gets
exactly. So we hook him up to the scrambler therapy. We start treating him. And the amazing thing about this treatment is patients see immediate results. So patients that have been in pain, so this guy's been in pain since 2015. And for the first time in 9 years, this guy is pain-free.
After
during the treatment. During the treatment and after. But, and I'll explain how that works. So the whole goal with each treatment is to zero the patient's pain.
Okay.
Like you literally zero it out.
So you scramble the bad signals.
Override the synthetic new signal, send that to the brain. Brain starts picking up the new signal as the normal signal. And the patient's pain literally melts away in just minutes. So then they're zero pain. And he's like, you know what? I can feel my feet. I can literally feel. So the first time in 9 years, I literally feel like I have normal feet. Like I can feel the ground. So he has his shoes off and his socks off, so he can literally feel the floor. So after the treatment, we take everything off. He stands up and he starts walking without his cane. And I had to like hold him as he stood up.
I'm sure he was nervous.
Yeah, and so during the treatment, before it really started helping him, his balance was terrible. As soon as the treatment was over, he stood up, he started walking, and wasn't even using his cane.
That's right.
It was unbelievable. I've never seen anything like it. And then we saw another lady with it was an amputee that had phantom limb pain and just terrible pain. Again, zero pain. So
how long is it on?
Yeah, so the first guy got relief for 4 hours, zero pain for 4 hours, and when his pain did come back, it was less. It was about 20 to 30% less than it was. Okay. So he came in and he was better today.
Trending in the right direction. Same with the other girl, but she had a little less time frame that it felt better. So maybe, I think it was maybe 45 minutes to an hour. Okay.
And then she comes back in today and she was, I mean, you see people in pain every day. You know, it's like, you could tell she was hurting. Yeah. I mean, she rated her pain scale a 9 out of 10, and it was visible in her face. Like you could tell it wasn't.
I'm sure
a
it was worse than normal because she had this relief.
Yeah.
And she forgot how bad it hurt.
Yeah,
so then when that rebound pain comes back,
it can be worse. Yeah, exactly.
I totally get that.
Yes. So she sits down, and within 3 minutes of her being on the machine, we zero her back out. And then she feels amazing, and she leaves smiling and happy. Yeah. So what the expectation is that each time we do the therapy, we get a little longer pain relief, and eventually we're going to break through to where we get more than 24 hours of relief, and then days of relief, and then months, years, or longer. Yeah. And so some patients will go through maybe 3 to 5 sessions, and that's it, and that's all they need. Great. Or some patients might go through 10. Most patients are going to go through 10 or less treatments. It's incredible. I've never seen anything like it. Yeah. I mean, it was literally almost miraculous.
You're scrambling my mind just thinking about it. I don't even know how to describe it.
I mean, I think it's a pretty fitting name. So I'm getting to go to Rome, at the University of Rome, in January.
I'm sorry.
It's terrible. I mean, I look for any excuse to like travel and do fun stuff, but get to go meet Giuseppe Marineo, the inventor, and train with him in the hospital and literally like treat patients with him.
Yeah, that'd be great.
So it's going to be a fantastic week.
So then we'll have to have you back on.
Yes.
And all of our viewers can see how the training goes and things are progressing. That's great. Yes. I had a similar patient with CRPS, which is a bad nerve problem. People know it's a horrible nerve problem in her arms. And we did a spinal cord stimulator. And the point is, when she came back and she had the trial, she literally ran and jumped in my arms and almost knocked me over because she said, I have my life back.
Yes.
It seems like very similar to what you're telling me.
Exactly. Yeah. Incredible.
And what else could you want as a doctor?
I mean, that's why we're here. To help people.
Yeah.
It's the most gratifying thing to change somebody's life.
Absolutely. Yeah. Especially to that significance of 9 years of having spongy feet and pain and everything. And it's all the things they don't tell you, but comes with it. The sleeping there, their energy goes down. They're feeling bad because they're not doing things with their family or friends. Yes. And then I
mean, this was the second girl I was mentioning that had the amputation. It was a crazy story. So she was 30 years old and get first day on the job as a police officer, get shot with an AK-47.
Oh, really?
Mm-hmm. And it blew out. So she had partial cauda syndrome. Thanks
to all the policemen out there and firemen and first responders. Thank you so much. This type of story, no one would ever know.
Literally, yeah. Just terrible situation. And she's lived with pain ever since. 16 years. That's great. She's been miserable.
Yeah. How old is she?
Yeah. Oh, young. She's she's 46. Yeah. Younger than us.
Can we delete that part out? Delete that part out.
Yeah.
So thank you for doing that. That's great that
amazing.
she could have that back, and these guys with their peripheral neuropathy are feeling better. That's
awesome. It's fun.
That's very good.
I love doing stuff that is just life-changing for patients.
Yeah, absolutely. And it's good that you're on the breaking edge and trending
Yes.
up and trying to learn new stuff. I think that's great. Very good.
Yep.
I should have known you were going to tell me something crazy like that.
Super
Always pushing boundaries.
Always.
That's good.
Yeah.
That's why you're so successful. Maybe I should take lessons from you. Cool. What else? Do you have any other stories to tell me?
Well, shoot. What do you want to learn about?
Well, first we have to have a word from our sponsors.
Okay, let's do it.
And we're back. Okay, go ahead and tell us another story.
You want to talk about something medical, something interesting,
whatever,
medical-wise?
something we can teach the viewers.
Okay,
the viewer.
So another really fascinating thing we're doing, and I don't think a lot of people. I mean, how much interaction did you get with interventional radiology when you were in medical school?
No, none.
Or in residency?
Very little.
Yeah, very little. Yeah. Probably any. Yeah. So when we talk about these interventional radiology procedures, most doctors, even high-level physicians, like I would consider you, obviously you're a specialist, so you typically know more than, some doctors for sure. And it's like you're looking through somebody and they just don't even understand and don't even get it. So there are some new musculoskeletal vascular procedures to treat. We're going to talk about a big fancy word here called angiogenesis. Okay. So angiogenesis, so for those of you who don't know and have never heard this, probably not many, I didn't even really understand this until I really started studying it. But basically what happens when someone is injured, our body grows vessels, new blood vessels, to compensate for the injury, to basically send in oxygen, to send in blood, to get things to start healing properly.
Yeah. You need oxygen and blood to heal.
Yes.
I learned that in medical school.
Oh, thank God.
You do need oxygen and blood to heal.
Yes. And if you don't have that, obviously things heal a lot slower. Right. So it's our body's natural defense mechanism. So it's like sending out an SOS.
It's why discs have a hard time healing.
Yeah, no blood supply.
There's not a lot of blood supply.
Yeah, so spinal discs are avascular. Right. And then when they get hurt, it just tends to get worse from there.
There's not a lot of blood and oxygen going to heal.
Exactly. Yeah. So the same goes with arthritis. So cartilage has very poor, if any, blood supply. So it's almost an avascular structure like the disc. Mm-hmm. And so when we injure the cartilage, especially at a young age, like maybe an ACL tear or a meniscus injury, it's sort of downhill from there. But patients may not experience symptoms for a long time, but these angiogenic blood vessels are developing.
These new blood vessels.
The new blood vessels, right. Yeah. And so they're new and they're somewhat abnormal to a degree because little tiny nerve endings get in there as well. So this is called neovascularization. So there's a nerve ending with all these new blood vessels. And the problem is a lot of these blood vessels are new. They're immature blood vessels and they leak fluid into the joint. So it causes an inflammatory response. And then it triggers cytokines and this starts a vicious cycle of inflammation and pain and inflammation. So when we start out early in the disease process, when we have mild arthritis, things tend to work okay, like ibuprofen, Motrin, Aleve, and it's able to overpower the effects of the angiogenesis because the inflammation is sort of mild.
Sure.
Then we progress to, okay, that doesn't work anymore. So the next thing would be maybe steroid injection. Steroid injection is a little stronger than the previous stuff. So that tends to work okay for a while. But then what do you do after you have knee injections for arthritis and then nothing else works? There's always been this gap in the paradigm between what do you do after knee injections? You typically have knee surgery. And it's a big step for a patient, especially if they're younger, like maybe 50 or maybe 60. And they're like, I'm just not quite ready for a knee replacement. So there's never been a stopgap in between until now. And so now what we do is we attack that source of inflammation by going in and treating those angiogenic blood vessels. And it's really simple. We just go in through a femoral approach, go in through the blood vessel, track a little tiny microcatheter under x-ray guidance. We have a vascular package on our C-arm. And so we see all this under x-ray guidance, inject a little contrast. There's 8 blood vessels that supply the knee joint. They're called the genicular arteries. So the procedure is called a genicular artery embolization. So what we're doing is we're blocking the blood flow just to the angiogenic blood vessels, not to the main arteries. Right. So we want to leave the main arteries
that are there from the injury.
That's right. And so the ones that are responsible for the inflammation and pain. So we take care of those. We knock those out by injecting these little tiny, we call them like particles of sand. They're actually made of like gelatin. the little flexible tiny balls.
Little
They're not microscopic, but it basically clots off the artery. So as we stop blood flow to that, all those vessels and those nerve endings that are causing a hypersensitivity of pain and causing your pain threshold to go down, making things that wouldn't normally be painful, we knock all that out and patients get better fast.
Good.
So they'll get better in usually about 3 to 5 days and start seeing big signs of improvement. And they may get years of relief.
Yeah, that's great.
Years, plural. I mean, it's unbelievable. From it takes us anywhere from 30 minutes to an hour to perform the procedure. Mm-hmm. It's unbelievable. I mean, it's almost as cool as the scrambler therapy.
I like the scrambler therapy. I like the scrambler.
Yeah.
And is that covered by insurance?
So the vascular procedure, yes, covered by most insurances. The scrambler therapy, unfortunately, not covered under insurance.
Still
cash
new.
procedure,
Still
but
new.
still amazing. Yeah, still new. Yeah.
Still new.
Yeah.
Okay, well, you're definitely cooler than me.
I mean, yeah.
I noticed you didn't
Always
say no.
have been, haven't I? No.
No, I'm not.
Okay,
That's what I'm expecting.
yeah.
You didn't say anything. That's okay. Very good. Anything else you want to tell us or teach us, our viewers?
I mean, I love what you're doing. I think it's amazing that you're spending time to educate patients. I think one of the hardest things in medicine today is, back to those insurance folks, a lot of people think doctors make a ton of money. And I mean, there probably are some physicians out there who do well.
Sure.
But reimbursements are actually quite low for what we do, I think, and the risk that you take. I mean, you're putting a needle into someone's spine, I mean, a millimeter sometimes from somebody's spinal cord that could be very precarious if you didn't know what you're doing, obviously. And you do this for like on a Medicare patient, like less than $200, and it takes like 15 minutes to do it, which doesn't sound like that takes long, but it takes like time to turn the room over and get another patient. So, I mean, it's a lot less than what people think.
Yeah, I agree.
A lot less. So, unfortunately, what I'm getting at, and the point is that insurances don't pay us well enough to spend time educating patients. I mean, I think you do a fantastic job because clearly it's important to you. I think our office does a fantastic job educating patients. So we'll spend the time with patients, but I just don't hear it from our patients when they see other doctors sometimes. It's like, oh, he just told me I needed this surgery or that surgery and didn't explain anything and walked out of the room and said, Mary will schedule you up the front. Yeah. And it's like, it leaves patients not understanding what their condition is. I mean, I can't tell you how many patients I've seen for knee arthritis that didn't understand that knee arthritis was just simply you were losing some cartilage in the joint. Mm-hmm. It does no comprehension, but nobody had ever taken the time to explain it, or what all the options were, how important weight loss is for the spine or for the knee joint. They say for every 10 pounds you're overweight is 40 extra pounds on the knee. So it's a huge deal to just lose some weight. So if you're 100 pounds overweight, you have 400 extra pounds on your knee. Yeah. I'm sure there's a similar statistic for the spine, for the lower back. Right. So if you're overweight and you're putting all that additional pressure on your disc, I promise the discs are wearing out faster than they should.
Absolutely, without a doubt.
And I guess there is such a thing as a disc replacement, sort of, in the low back. I think it works better in the neck, but
less weight.
Yeah. So, yeah.
But you're right. That the problem is that medicine is becoming much more of a business than it is an art to helping people because of the nature of the business. You have to generate money because expenses are going up and people want to be seen. And you don't.
Did you get a raise when inflation went up? Did Medicare call you and say, Dr. Moran, we feel so sorry for you. We should give you a raise. Because I think everybody got a raise but physicians. And
it goes down.
And it goes down and down and down. I've never seen an increase in reimbursement in 21 years.
Yeah, I've never seen it.
Never.
Yeah. And the problem is we don't get paid to educate patients.
We don't. There's not a code for
Which is probably one of the most important things.
It is the most important thing.
Yeah,
I mean, one of the guidelines in the American Academy of Orthopedic Surgery recently talked about how important educating a patient on arthritis was. Mm-hmm. And it was literally one of the key components and one of the most effective things you can do for arthritis. Yeah. But I guarantee you that's not being done very well.
Yeah. Which brings me to my point of my online course. So I have an online course. I don't know if you know about that.
No, I did see the text where you sent out a huge text thread to a lot of people. And you were announcing.
You're the only person I sent it to.
I was the lone one. No, I did see that you were making a push to do something really cool and innovative, and I've never seen a doctor do this. So congratulations.
Well,
that's
thank
amazing.
you. That's part of the problem. So did you know I got my MBA?
What? I can't say I'm surprised.
I got my MBA last year, and my graduating project was come up with a business.
Nice.
So I decided to come up with an online course because right now I see patients one at a time. But on an online course, I can see patients multiple at a time, 24/7.
Yes.
So I came up with the world's biggest cause of disability, which is low
back pain.
Low back pain.
Shocker.
So I went after that, and I came up with this video course. It's called 1 Month MD. I can teach you everything you need to know about treating and causes and prevention of low back pain in 1 month.
Nice.
So it's 1 month MD, and we're doing low back pain causes. So it's 10 minutes a day for about 4 weeks, and I give you Fridays off.
Well, that's awfully nice.
Right.
Yeah.
And what I'm trying to do is I'm trying to build a habit for patients to take 10 minutes while you're having coffee, you're relaxing, watch the videos, and you can learn about the causes and treatments of low back pain so you can be an active participant in your health instead of a passive recipient. And then you're halfway to developing a habit to using that 10 minutes instead of watching videos.
It's ingenious. That's ingenious.
Go do yoga.
I love it.
Try to do some exercises.
You know, I will tell, speaking of yoga,
Uh-huh.
I will tell you, I tell patients all the time, if people would just do yoga, I mean, it would put chiropractors out of business. I swear to you. Like, I'm a huge proponent of yoga. So if you've never tried yoga, go try it. It's amazing.
You know what?
Really get into the habit of it. It's awesome.
How many doctors in a small room doing a podcast will agree yoga is important?
Well, 2.
2 out of 2. Because I love yoga. I do yoga all the time.
It's incredible.
I did one this morning. It was actually really hard this morning. And I totally agree with you. I think that after 40...
I think I did yoga with your brother one time. Do you remember that?
I do remember.
Yeah.
That's another story for another time. But I think it's very important. I think anyone over 40, just to mobilize the joints and get stretching and range of motion, yoga is one of the easiest and best things you can do.
It will melt spinal pain away.
Yeah.
I mean, there may still be some underlying issues there sometimes that still need to be treated. But I'll tell you, for the most part, it would greatly improve function, flexibility. I mean, a lot of things.
Totally.
And then the things that you do and potentially the things that I do would work better and last longer.
Yeah.
And they would need us less.
So we need to have a yoga master, a yogi. We need to have a yogi on the podcast. Attention,
that would be good.
Attention, all you yogis out there.
Yeah.
If you want to come on, let me know, or maybe I can invite some of my friends that do yoga.
Yeah, absolutely. Yeah. That's a great idea.
I'm actually having a personal trainer on that does yoga, so maybe he can teach me some new stuff.
Well, there you go.
But yes, totally agree. Yoga is the key.
So tell me about the course. Is this something you're going to test people on?
Well, a lot of times I just encourage patients to go do it or see what they do so they can get the benefits. And
now, do you know how much they participate in it?
Yeah, we can track them.
Oh, awesome.
We can track them, and at the end they get a little certificate. And we're going after everyone. It's not just patients; it's employers because patients with back pains, healthcare expenses are 60% higher with back pain than without. Any employer in the country will have 15% of their workforce lose 10 work days a year from low back pain.
Oh, I believe it.
So think about the revenues on that. I just did a talk for a big school district. They have 20,000 employees. So every year they have 3,000 employees that lose 10 days a year from low back pain. So that's 30,000 work days a year they're paying for substitutes.
Smokes. Yeah. That is unbelievable.
Yeah, it's crazy.
And that's, I mean, the burden that is on the system is tremendous.
And talk about that is, we do all these things. I'm kind of getting off on the subject
lost productivity.
for taking care of the students, but fundamentally, to take care of the students, you have to take care of the teachers. So
True.
They say, why would you focus on investing in all the students' well-being and health and education and strategies to train them to be a better teacher? You have to take care of yourself.
Right.
And the example I give is when you get on an airplane, what does the stewardess say? First, put the oxygen on yourself.
Yes.
So you can help others.
Isn't that the truth?
So you're taking care of yourself so you can help others. I'm taking care of myself so I can help others. Teachers need to take care of themselves so they can help others.
Well, and you've seen what fantastic shape this guy's in, so it means a lot when you go to a physician who does take care of themselves.
I like to practice what I preach.
That's right.
Yeah.
That's awesome.
And you do too.
Yes.
Very good.
100%.
Very good. So is there anything else we need to share publicly, or we can share publicly, or do you have a funny story you want to tell me, or are we just going to say
funny
enough
story?
Is enough? I know you have a funny story.
Oh, funny story. Nothing's coming to mind. It's almost the holidays.
Yeah.
Leaving tomorrow, family trip.
Nice.
Portugal and Morocco.
Nice.
So super fun. So my son, mentioned flying earlier, my 17-year-old is applying to the Air Force Academy.
Awesome.
So on December 1st, he applies for summer camp. And if he gets into summer camp, it's really good. But I mean, he's doing amazing. Super cool. Super fun.
That'd be awesome. That's a great school.
Yes.
I've been there. Have you been there?
Yes, it's incredible. We went
awesome.
in March for a tour.
Very good. We'll say, tell him I said good luck.
Absolutely.
And let me know how he does.
Yes, absolutely.
Okay. Very good. So, Kevin, thank you so much for coming on.
I appreciate it.
You taught me a lot of good stuff. So
all right.
Teach me good stuff. I'm always interested in learning new stuff. So you taught me lots of good stuff, and I appreciate that. I'm sure our viewer really appreciated it.
Our one viewer?
Hopefully it's more than one.
Yes.
We're trying to help out.
That's right.
We're trying to do our job.
So tell your friends. Tell your friends.
Right.
Yes.
Go see Dr. Kevin Barton and Texas Spine Clinic. Is that your name? Oh, yes, that's right.
Yep. Yes.
That's right.
Yeah, that is my name. Yes. Texas Spine Clinic. And then we have our sister business all in the same building is Arthritis Relief and Vascular Centers. So with that business, we focus mostly on knee arthritis and then joint pain in general. We don't do a lot of spinal stuff over there. And then the new vascular stuff that we talked about, we do uterine fibroids as well.
Oh.
And we do men with large prostates. Mm-hmm. Know anybody with large prostate?
I'm sure I do.
Statistically, they say anyone, so men over the age of 50,
so not
50%.
Me. So not me.
No, next year. So men over the age of 50, between 50 and 60, 50% will have an enlarged prostate. And then, so we'll talk about this on another podcast, but it's just really cool stuff.
So you're going to come back?
Well, maybe if you invite me back. Yeah.
You're always, you know what? I'm going to give you a lifetime membership to the podcast.
All right.
Bring some tools, bring some games, we'll have some fun.
Hey, whenever you're ready to have me back, I have a lot of other really cool stuff to talk about. So our whole mantra is we're trying to give people better options than surgery.
Okay.
With less recovery time, less risk, and get them back to feeling good and back to work in a very short amount of time.
That's great.
Yeah,
totally
week or less.
Yeah. Surgery is great when you need surgery.
When you need it.
When you need it, surgery's great. But
it goes back to that conservative approach and starting out with the things that make sense first and then leaving surgery as a last resort.
I think that's very logical.
Unless it's an emergency.
There's reasons to do anything.
There is.
Yeah, very good. Yeah. So thank you so much.
Thanks for having me. Thanks for having me, Dr. Moran.
Thank you guys. And if any of you guys have suggestions or want to come on and teach me about something or talk to your community, please let me know. We're happy to help out. Otherwise, we'll check back later. Thanks a lot.